All right, let the death by PowerPoint continue. I'll be the executioner this time. It's just one of those things, it's like you just got to do it, right? Like either you give people nothing to look at or you give them something to look at, and hopefully what you give them to look at they find entertaining. At least that's how I look at it. This particular part of the conversation is sort of the segue into allowing us to sort of talk and have other questions coming forward for all the panelists, et cetera, et cetera. But the idea of trauma-informed communities of care, I owe a debt of gratitude and just sort of acknowledgement to where the whole notion of trauma-informed comes from. My colleagues at VHA a couple of years ago ran a conference because they were looking at what would trauma-informed practice look like in VHA across the different segments. Trauma treatment's one thing. But trauma-informed practice for them is how can we do this? How could we, like if someone's being triaged in an emergency or someone's going to the sexual health clinic, what if we were trauma-informed? What if we knew about trauma? What if everybody knew something about trauma? Would we change our practice in any way? And this got me to thinking afterwards about, well, on a larger scale, on a Canadian scale, what if Canadians en masse knew more about trauma? What would that look like? Would it matter? So this is where sort of putting up some questions here. We know that trauma is part of human history. It just is. Like we've heard it all now. The war's been around since time immemorial. People have been abused, killed, all these things. So it's not a weird thing. It's just part of our existence here. But as a lot of people have seen, they've also generated some of the most compassionate acts that we've ever seen. We see the pictures of the soldiers holding kids, people helping veterans when they come back. So it's not all doom and gloom, If you think about it philosophically, every action has an equal and opposite reaction, blah, blah, blah. We won't go into that kind of philosophy at the end of the day. We'll save that for morning time. And truthfully, we've never really understood more than we do now. Even with all the stuff that we don't know, there's never been a time in the history of our understanding of trauma where we've known more about trauma than now. It doesn't mean that we stopped. There's probably going to be a lot more that we learn. And, in 20 years, look back and go, oh, God. Do you remember that guy, Tim, doing the VTP? Remember he thought that that's what was helping? What an idiot, to use Chris Linford's term. Who knows? That could be the case, right? We don't know. Like, we look back and say, oh, what the hell did Freud know? Well, we have the luxury of now 100 years of looking back and seeing what he's done. But we know a lot now, and I think we should capitalize on that. And this is just sort of summary points. To me, as I think about this, human responses to trauma are not abnormal or pathological. They're just responses. Alan Wade also attended the trauma-informed practice session with me up in Nanaimo. And Alan's got a great perspective on this in terms of when people have things happen to them, they don't just react, they respond. Everybody. And if you look at as a trauma therapist, you see this. Even children respond. They respond actively, trying to dissociate, trying to disconnect, trying to cope with, they always are doing something. It's not pathological when these really extreme things happen. They're most times understandable and logical consequences. And I always say in therapy, there's no mysteries. As beings, we're pretty rational. It's just that we don't yet know why you're responding this way. Once we can figure out why you're responding that way, then we're off to the races. But usually it's that we don't understand what the response is from. Is it because this happened or because that happened? If you spend enough time. We've talked a bit today about sort of the speed at which therapy works. I came through the era of EMDR where big controversy because EMDR said they could change things and all this kind of stuff. And the humbling thing that Marsha Walensky taught me, who does all the training for EMDR here, is that EMDR works faster. And what that means is that if someone needs 6 years of intensive psychotherapy to get better, you can do it in 4 years with EMDR. And to me, that was like, oh, okay, well, I can do that. And same thing with EMDR. It's very much like EFT. There's some incredible results that happen, like very quickly. I mean, it's incredible. And there's some interesting research around what might be going on there. We do know this stuff, but again, a lot of this stuff is really understandable. I think part of the thing that I try to get around, and I think Alan would agree with me if I don't want to speak for him, is if we treat the responses continually as pathological, as we use the disease model, this is a problem, this is disorder. I use it, I talk about PTSD, et cetera, et cetera. It's part of our collective awareness that there's something wrong with you. But really, if you look at what's happening, in the brain, it's actually pretty understandable, right? It's almost like saying if someone runs over my foot with a truck and my foot breaks, that's a pathological response. Well, not really, actually. Like, it's actually pretty understandable. Like, the truck went over my foot. Like, there's nothing wrong with me. The thing ran over my foot. Like, but we treat trauma this way. Okay, so someone put a gun in your mouth and told you they're going to kill you, and now you're having nightmares. And, oh, well, that's what a pathological response. Well, actually, no, it's not. It's a really understandable response to what just happened. But we use this language of disorder, right? There's something wrong with people. They're crazy. They're shell-shocked, etc. It's not to say they're not suffering. The option of not treating it is also not an option, right? So we can't just say, oh, it's a normal response, let it go. No, I mean, people suffer immeasurable kind of pain, psychic, emotional, and otherwise, so we still have to treat it. So, question, this is the audience participation part. What do this guy, anybody know who this is? No. Anybody here grew up in Ontario? Nobody did? That's the problem. They all moved out here and then grew up. This is Murphy the Molar. Anybody remember Murphy the Molar? Well, that's a product of my generation, I suppose. Okay, what do Murphy the Molar, who's this guy? Everybody knows Smokey, right? Yeah, West Coast forests, right? They don't have this on the prairie. Smokey the Bear doesn't. What's that? That's right, so it's a pretty easy question, right? Yeah, exactly. And? Well, we know it's Elmer and he's an elephant, but what kind of elephant is he? He's the safety elephant. What is wrong with this guy? Like, what is this? Yeah, this is what your taxpayer dollars go to. Guys like me teaching people who come and pay good money to come to the university where I teach at. But bear with me. So what do they have in common? Well, here, that's certainly true. I didn't anticipate that. I thought, geez, there's something else. But in addition to nobody knowing who they are, they actually change the way that we view the world for those people who know who they are. And they actually all reduced harm. So fewer cavities, healthier teeth. I mean, we know that. That's just one of it in terms of brushing. Fewer man-made forest fires. It was public education. And fewer road deaths. There's a CBC piece that was done on this, looking at the impact of Elmer the safety elephant. So why am I even talking about this? Why am I talking about this? Because I don't see this as any different. I actually don't see trauma as any different than kids dying on roads, people having cavities in their teeth, or forest fires burning down people's homes. Education. It probably affects more people, trauma, than forest fires do. How many people here have been in a forest fire? Few of you, right? I won't ask for a show of hands, but I bet there's more hands in here for people who've experienced trauma in their lives. Just a guess, right? We've all probably had cavities, right? None of us have been killed in a road accident, but maybe some people know people who were killed in road accidents as kids. They're education pieces. My idea, and what I'm asking the question here is, what if, okay? So, what if communities in Canada learned a few simple tools for dealing with traumatic events, like a trauma toothbrush, right? Once Murphy the Molar came out, it was like, everybody gets a toothbrush. Go to the dentist is going to give you a toothbrush. Schools, everybody gets a toothbrush. Well, why doesn't everybody get 5, 4, 3, 2, 1 grounding? It's a free grounding technique that costs nothing. I could teach all of you in 10 minutes how to pull yourself out of a dissociative state for free. And then you take it with you, like the tapping. You just take it with you, right? It's actually really easy. And guess what? It's not contraindicated. It's not like handing out SSRIs, right? Celexa, here everybody, there's a pill, go try it and see what happens. There's no side effects, but it's there. How do I know I'm a trauma therapist? What do? I teach my clients. Why can't I teach a group of kids? Why can't I teach a group of adults? Okay? Trauma toothbrush. Take that one. If you take nothing else, see, the primacy and recency effects in memory go like this. You always remember the first thing from the day and the last thing. I'm going to burden you now with the trauma toothbrush. So take that and do with it what you will. What if communities knew how to prevent the shame that traumatized individuals often experience? We don't talk enough about the shame that people hold and why it isolates them from the rest of their community. If there's one thing that does people in and around suicide, it's that people go inside themselves and they separate from those people around them. One of the symptoms of PTSD, inability to feel loving feelings. Part of it is also the shame. When I got stabbed, I had people saying to me things like, well, I guess you'll never do that again, will you? I'm like, no, I won't. Thank you. I won't do what I was just going to do because, you know, it's online, and if this could go viral or something. And it's like, there's that guy from the university giving the finger and, you know, whatever. But anyways, what if people knew how to prevent that? Because we do know that that's a huge piece of it, right? People get raped, people get assaulted, and people, well-meaning individuals actually say, well, why didn't you do that? What were you doing in that bar at 3 a.m.? Questions like that lead to PTSD. And it's simple. What if everybody knew, hey, don't do that? Someone in your family gets in a car crash, don't say to them, how fast were you going? Don't do that. You'll prevent PTSD from not asking questions like that. What if, what if, what if? What if everyone who ever experienced a traumatic event in their lives knew it wasn't their fault and they weren't crazy? Then, what if every person in Canada understood what a traumatic event can do to a person and why? Part of this forum, part of what Roger's trying to do is say, hey folks, let's educate ourselves, let's talk about this because it's happening everywhere. It's happening right now. Someone's just been in a car crash, someone's just been assaulted, some kid's just been smacked in the head. It's happening right now, we know it is, right? What happens in the brain? What happens to people? It's normal, it's understandable, but it's causing problems, okay? What if every person understood that post-traumatic responses were normal reactions? It go a long way to reducing the shame, right? It's not that it's, just because it's normal doesn't mean it's good. Like I said, when the truck runs over my foot, say, it's okay. A crushed foot is a normal response to a truck driving over it. Okay, thank you. Now, give me some pain medication or do something because I'm in pain here, okay? It doesn't make it all right to know it's normal, but it can help. Better than someone saying, well, what were you doing putting your foot behind the truck? What's your problem? The damage that happens when people ask those kinds of questions is real, okay? So the current situation, really trauma is currently the knowledge of the rarefied knowledge of those of us who've been trained in it, people who've taken courses. It's not really public knowledge. Why not? It doesn't have to be specialized knowledge, okay? And the general population really doesn't understand this. It doesn't. I hear people talking about PTSD. I hear people talking about how they were traumatized because they couldn't get that sweater on sale or because the car they wanted got scooped by some guy who got there earlier. No, you weren't actually. You weren't traumatized. I guarantee you weren't traumatized. You're upset, but it's become part of the lingo. It's getting watered down, okay? So what would trauma-informed communities of care look like? Just think about the different places. Whoops, here's our friends. They just got to jump out at you there at the end of the day, don't they? How would it look in schools? I did some work in a school where a horrific tragedy happened to one of the students by some of the students in the school. Worse, murder. And I was brought in to say, hey, school's starting and the trial's starting too. How are we going to do this? How are we going to get through this trial? So we talked about, well, what do you need to know about trauma to help the kids and to help the teachers? Giving them information. Simple things like teaching kids about self-regulation, like putting really beautiful pictures of things up in the front corners of the wall. And if your kids start to dissociate, tell them to look at the picture and start doing some breathing. It doesn't matter if they're not paying attention to the lesson, just let them do that. And if you're a teacher teaching traumatized people or interacting with people, put those images at the back. If you start to feel that stuff, just tune into that for a little bit. It's literally about drawing your attention out of the horror of what you're dealing with and into more things. Like I say about how many people took an opportunity after I said what I did to actually look outside and look at the water and look at where we live. It's all around us. If you didn't, don't feel guilty, but just do it. Just do it, yes. I'm almost done too, so I'm gonna open this up.
Encouraging that the Vancouver School Board is doing something called Mind Up, which is based on Thich Nhat Hanh's teachings.
Cool.
Which is basic breathing, meditation, bringing yourself back to the moment. But they couldn't call it meditation.
No.
So they called it Mind Up.
Right.
So if anybody wants to Google that, but that's in our schools.
Mind Up in the Vancouver
Mind
School
Up.
Board or Victoria? Vancouver, thank you. Mind Up, teaching breathing techniques, but don't call it meditation. And whatever you do, don't call what you're doing therapy if it's helping, just don't even go there. Whatever you do, just do it, right? But don't call it therapy because someone's going to come and talk to you about that. So what can we learn from these three? I don't know. You talk about like positive memories from childhood. I got all these warm fuzzies. It's like, can I find a picture of Elmer the elephant? It's like, there it is. And it's even like the colored pencil version. It's not like a digitized, really cool version. It's like they did that with, I don't know, like Crayola paint pencils or something. So trauma treatment, really, in terms of treating trauma, it really does have to stay with people who are highly trained. You can harm people. You start doing trauma treatment and you don't know how to do trauma work, you can harm people, you can re-traumatize them, you can cause a lot of damage. Even really well-meaning therapists with basic training can do a lot of harm. So just get trained and keep it in that realm for the people who are actually doing trauma treatment. But for me, in terms of trauma-informed communities of care, just giving the information, practical information, that's really, really important. It requires capable translators. One of the things we don't do often well as psychologists and psychiatrists and mental health professionals is that we have a hard time switching out of our technical language into language that people understand or even want to listen to. So we need people who can translate the information to communities that actually don't speak sort of psychobabble, as I'm always accused of doing. Okay? And I think we can actually start with this forum, really, as a place to start. We had a lot of talk about military, but we're talking a little bit about civilian. And the notion of trauma-informed will include trauma treatment, will include PTSD, but I think it can be a lot bigger than that. And who knows, maybe in 10 years we'll say, hey, it all started on the West Coast in Victoria, and now every kid has like a little, like Timmy the Trauma Troll or something, button that he wears, right? Named after me, of course, right? Yeah, that's not narcissistic at all. So anyways, just to finish this up, and I'll turn it over to Roger for discussion, but I see this as a seed being planted. It doesn't necessarily mean it's going to grow. These things don't happen without effort and time. I want to thank Roger for putting it together. It really was his vision to put this stuff all together. So thank you very much, and I'll just say thanks to everyone involved.
Starting to feel like Oprah.
Love Oprah.
Yeah. And so maybe we just start having a bit of the conversation from that community perspective. How many of you small nonprofits still feel lonely? Are you a civilian and don't know where you might go yet? My friend Hazel she's double-headed. She does the Schizophrenia Society and she's Canadian Mental Health. She asked me to remind folks that there are brochures there with a self-help angle. A place to start, and it probably won't be the place you end, depending on what your needs are, but at least you know that there are places and organizations out there. And so, let's start it going, and I'll let you have a chat.
Okay, I'm just thinking about you asking us to look out the window. I actually have an app. I have several apps on my iPhone. So one of them is put out by the American Vets Association, particularly for PTSD. It has an assessment tool. You can track your assessment. You can manage your triggers. It, has about 8 different categories about what's going on for you, like reminded of the trauma, do this, disassociating, do that. So there's some really cool tools available.
What's the name of the app?
I don't have my phone here, but I can tell you, my daughter actually has it in the room out there because she's playing while I'm in here.
And let me just perhaps turn to my speakers today, and I appreciate all of you being adaptive and flexible and going from metric to imperial minutes. In terms of the entirety of the day, from that foundational, we're big systems, to there are some new, perhaps emergent bits. Can I get some thoughts or perspectives from you two?
No, I think it's been an incredible day. I think, there's a whole bunch of topics that we could have touched on beyond sort of what we've done. I mean, Chris, excellent talk. And I mean, in trauma world, I mean, those of us that do the work, we struggle with at what point do you bring in the concept of post-traumatic growth? Okay, it's a well-documented, well-studied, Tedeschi and Calhoun have published a whole deal on it. You bring it in early. You say to somebody, well, your friend's dying and all that stuff. There's got to be something positive out of it. I mean, it's not right. It's not the right time, right? But Chris, you embody post-traumatic growth right now, and read the books. I'll lend them to you. I've got them at home. But I mean, the idea of, you put up sort of the Ontario-centric ones, Tim, and I'm from Ontario, so I didn't want to admit it to the group, but but it's it's interesting because one of the other examples of post-traumatic growth actually is Mothers Against Drunk Driving, right? It's the best example in terms of, here are these sort of soccer moms, these sort of nobody kind of people that are going to sort of live their lives, they lose their teenage kid, and all of a sudden they have done more to change attitudes. I mean, for those of us that have been in the military know the attitude change in our organization. More has changed when you think about drinking and driving because of these people than laws and any other education, right? So that's post-traumatic growth, how people can take the trauma that they've had, you know, digest it, get treatment, get better, and then take a look at it. I often, you know, I have the privilege of meeting with Senator Dallaire quite often, and he's an example of post-traumatic growth. So here's a guy, you know, 1-star, 2-star, whatever he did in the military, is going to pale in comparison to what he's done afterwards. And it's because of that trauma and because of getting through that trauma that his eyes have opened. So I think the post-traumatic growth piece is huge, and thank you for that and sharing for that. And what you're going to achieve now is going to have a more lasting effect than staying as an HSO, light colonel, whatever would have happened. So I think that's great. I think the community piece is really important, and I think some of the work that we're doing actually talked about sort of training. I mean, our resiliency training that us, the Australians, the Americans, are all sort of committed to the resiliency training for leaders, for all of this stuff, coming from sports psychology, teaching people sort of the big four, teaching people skills. And what we are doing is looking at that, and our hope truly is to get that into the corporate world, to get that into schools, because whether it's going to prevent PTSD or not, we're increasing people's coping skills at the time. So it's aimed at 100% of people, not for after the trauma, before the trauma. We're starting at basic training. And thanks to True Patriot Love and Bell, we're hoping to get a bunch of money to actually do some studies to definitively do it. And if it works out, then it's going to come into the corporate world, hopefully in the schools, teaching people basic coping skills, as you've said. I think we need to go beyond PTSD. I know that's the purpose of the forum, but really it's about compassion for mental illness. And with the Canadian Mental Health Association, because as big as PTSD is, I mean, I'm a psychological ambulance trainer, as you probably are as well, Tim, you know, depression's bigger, you know, and there have been fantastic studies that have shown, you know, after trauma, the kind of trauma we've been talking about, depression is actually more common than PTSD. You know, we've sort of talked about PTSD because it's kind of the thing, but so I think when we talk about stigma, barriers to care, and attitude, it's a compassionate approach to people that are struggling, because one day you'll be struggling, you'll know somebody that's been struggling, and the best thing that's happened for the military actually is a lot of our senior officers have struggled themselves or know somebody that's struggling, and that's helped make our attitudinal shift. So I think the community thing starts. I'll stop there, I'll let other people talk, but I think it's been a fantastic day.
I want to thank Roger. I think this is a brilliant day. I think you started off the day also giving us a great introduction. Sure. In terms of the messages that I've got today, especially in the last 40 minutes with Tim speaking about depathologizing trauma, very, very, very powerful, and I think destigmatizing that whole domain is certainly foremost, and it should always be there. And I'm sure we're all striving to do that. At the same time, we have to make sure that we put a lot of resources into continuing to do a lot of research that's required to improve the services. So I like your community message. I think it should be widespread. At the same time, I think the resources need to go to study this further. As I started the day, I said I came in 1978 as a psychologist. In 1980, that's when we first started to use the term PTSD. It didn't exist before. And we think we've come quite far in terms of 32 years. Is it 32? Yeah. Actually, we've come far, but there's still a lot more, you know, and the enthusiasm of some of the projects that I hear are great. Again, I stand by, you know, the rigid methodologies and so on and so forth. That doesn't stop the process of continuing to learn and explore the world of trauma and all the related disorders like you were mentioning. So that's my message for the day. And I hope this is the first of many, okay? This has been very successful. And on behalf of VAC, I'm very pleased to be here, and I'm very pleased to take some of these messages back to my colleagues at the National Center.
Great, thanks, Juan. How about any other questions at the local level? How about my friends in the constabulary? Did you get your money's worth? Have you made the exchange of information, a couple of business cards, you know, who go talk to? How about my small nonprofits? At Men's Trauma Center, in fact, I swapped a note with the gal that works there. She tells me $200 a year. You know, down on Pandora Street, $200 a year come in, and it's PTSD that she's treating. They're not all military, let me tell you. And the reason she's not here is this week she's just overwhelmed. And so capacity, we talked a bit about that, capacity to be sure. And a research question, you know, I think on Karen's behalf, with so many potential modalities out there, and maybe one of them's the miracle and we don't know yet, how do those potential research convince the funding bodies, and we all know how well research funding is going these days nationally, how do they get visibility to sell themselves, to get a little bit of the slice of the research dollar, to find out if they're good enough to share the scene of health providers?
Well, yeah, if I can sort of just answer that briefly, and I think I spoke to Tim before. In terms of partnering, the idea is sometimes funds are short, and for clinicians, especially those that aren't affiliated with research groups, it's even harder. Some of my colleagues are doing this very, very actively, which is you partner with institutions that are actually doing quality research, and with that partnership, perhaps try and invent avenues so that you can foster some of the ideas that you have in order to develop them into real workable treatment modes, you know.
I just wanted to mention, unfortunately, the last half of my PowerPoint went with the movie. So because of the commitment of the people who've been doing research in EFT with the military in particular, they've managed to lobby not only government, but also the Department of National Defense in the US. And they're commencing a study, I believe it's going to be 500 people, comparing emotional freedom techniques with cognitive behavioral therapy, along with traditional care. I would love to see Canada take a similar stand. I think that if the Americans are willing to put that many dollars and time into a study like that, they've obviously been impressed with what they've seen and the reports they're getting back. And I really feel Canadians are different. We're not Americans. Our issues are different. We've got a lot more peacekeeping missions with different issues in them. Yes, it's PTSD, but I really feel, I'm hoping that we can, if some of you military people are wanting this, start sending your emails to the right places, and hopefully we can find ways to do that. I think Victoria could be a model. We're often very innovative here in Victoria. We've got amazing networking capabilities, and Roger's one of those people. And I would love to see a way that we could cooperate and get some of this research done. It doesn't have to cost a lot of money. The savings of having people learning how to do self-care instead of depending on the psychologists, psychiatrists. I didn't get to show you the slides of my single patient study, but this was a person with 18 years of PTSD on 14 medications, non-healing wounds, off work on disability for 3 years, had worked really hard to bring himself forward. He'd been in AA for 8 years. He'd done a lot of work with various psychiatrists, psychologists, etc. And he was still suffering every day of his life. He couldn't go anywhere. He had social avoidance. He was awake with nightmares, couldn't sleep in the same bed as his wife because he'd just kick her and trouble her. Within 3 treatments with emotional freedom technique, his PTSD scores and, more importantly, symptoms started to drop. And even with a break in therapy that maintained for another month, 3 more sessions. His wife came to a number of the sessions. She also had PTSD. She treated some core traumas from childhood as well as her own career. And the two of them now use EFT regularly. Their whole relationship has changed. His non-healing wound started to heal. I mean, I do think that we can't, you can't take one case, but if you look at all the cases, and unfortunately, although they are going to play this video, I really hope you can stay and watch it because it's pretty inspiring. So I think we could find ways, if we really wanted to get some research started here, and I hope we do.
Karen used the word passion a little earlier. It was a word that came to my mind when I was watching Athol tap dance and do his techno magic. The practitioners I know are very passionate about this. I think we sometimes have to remind ourselves that the modalities aren't competitive. There are some folks who have a sense of ownership that is probably a bit more than they should display. To me, as an observer and a leader, all I'd like to see is a range of complementary tools to have in the box from which we can choose and get results. And if we can get there, then maybe we start making life a little easier for some folks. You know, it's complex. I know a guy, and he doesn't have PTSD, and he feels guilty about it. Figure me that one out. You had one here.
I just think we've talked about so many amazing different ways to treat. There's a lot of programs out there that are incredible, and there's evidence to back up that they're effective. But what I see as a military member and as a civilian therapist is there's so many different programs. So is there a one-stop shop, either online, where they list the program, who might be a good candidate for that program, who might benefit from that program, and how can a person who's either dissociated from the military or from whatever the case, they don't have the resource to connect with those programs, how can they find the one that's suitable for them?
Yeah, I'm worried about that dissociated military individual. I'm also worried about the civilian, 2 years after the car accident, and they have even a worse network. I have no knowledge of a one-stop shop. Tim?
It's not a necessarily one-stop shop, but David Baldwin's Trauma Pages is a great resource. Just if you have anybody who's looking for something, it's got articles, it's got stuff that's self-help things. It's been around for a long time, and there's a bunch of different sites that you can go to. I think, these are the kinds of things that sometimes at a forum for like these actually get created, where someone says, well, actually, I know a guy who's a webmaster or a person who's really good at this, and why don't we do the Railroads University PTSD Forum one-stop shop for treatment options? Start locally and then start building it, provincially, nationally. It's a great idea, but David Baldwin's Trauma Pages is one place to start anyways.
I think the other good place is the National Center for PTSD in the States. A lot of educational, self-help, all the different kinds of material. I think, your question's a great question. For somebody while they're serving, your one-stop shop is the MIR, is the people that are there. And so people at each base will tap into the local resources, know the expertise that's around. I think the challenge becomes when you transition out. Now, the Veterans Affairs can speak, but I mean, they've got their network of clinics, and they're and we share the list of Blue Cross providers in each community that are sort of not certified but have demonstrated the expertise and this kind of thing. The real problem ends up being the other part, that whole list, right? That whole list, and there's many passionate people out there that sort of believe very strongly in the work that they do. And it does work for them. I mean, and they're finding that. They're looking at people and they're getting better. And I think when you sit in an office like I do, I'd say between 1 to 2 things a week come my way. Sometimes fired to me from Senator Dallaire, sometimes from retired Lou McKenzie, sometimes from this. And the list is incredible. EFT comes quite often, but it's EFT, it's soapstone carving, it's agritherapy, it's pet therapy, it's equine therapy, and so we're sitting here struggling actually with all of these because they're very passionate, and there's a merit in every one of them. Every one of them has done, you know, if with equine therapy, they've done studies pre and post. With other things, they've done it. So there's a real challenge in terms of developing such a list in the sense of, you know, what's there, and that becomes a challenge for us, and it must be even more difficult for somebody that's suffering to kind of find their way through it.
I just wanted to take a minute, Roger, and really thank you for the day and just put an idea out there with what Tim finished off with. I'm Marianne Ostapovich. I'm from the Military Family Resource Center, and I'm a registered clinical counselor and social worker. So I work with both families and military members, and just wanted to put the idea out there for people to be thinking about. There was on the CBC, there was an interview of a fellow that came back in an Army uniform who had some really traumatic experiences while he was overseas. And he said there was a forum in Ottawa, and he said anybody who goes overseas that does not come back affected in some way. So they call it PTSD, a disorder. But he said really what we need people to recognize is if you come back as a human being from being posted somewhere and you're not affected, he said, I would see that as a disorder. So I just want to put that plug out there. And then a plug for our center, we have a national program called the Navigator Program. So www.navigator.com. If you're a professional here today or even a private practitioner and you want us to know your information of how you're working with families and members, please send it to us. If it's appropriate, we'll post it on the site, or we have many links and it's a popular site. But I really just want to take the time, Roger, to appreciate everything you've done and all the work that's gone into this.
So I have two things here, and one thing is on the comment about Canada being a smaller nation. It was just made here a few minutes ago. It's very important to understand when we rely on studies from other larger nations, Britain, the US, things like this that have more funding, that do these studies. The way our soldiers are trained, our societal values, they are much different than that of larger warring nations. The impact on our society, because we are a large country and a small nation, can be much greater. So the statistics, even though they're applicable in the form of a guideline, the impact and the numbers game can be much different here in our country. And it comes a lot down to how we're trained. Which brings me to another point. Tim, on your slide, one thing I think we just kind of skimmed over is we have a habit of looking at things on a surface. And what I look at when I see those three items is the programs and their success over time and their rate and the reason why they were successful. And I think what it's attributed to, if you look at defense through design in program structure, is early education in prevention. So if we, you know, you can look at a child, but more importantly, you know, soldiers also when they first join, or sailors, airmen, sorry, soldiers, sailors, and airmen, you know, they're also children in the respect of what they're learning. Okay, and so, you know, it's all new when you first join, right? So the training in early prevention and what the effects of that, it makes the transition process later on much more palatable, easier, but more importantly, it makes the success of the program, as you can see, almost 100% over time. So, comments?
This has been a very inspiring day for me. I just wanted to say that I'm planning to make a documentary about PTSD and domestic violence. Excuse me, and Judy Jackson is a personal friend of mine from Salt Spring, and she is the woman that produced War in the Mind. So I'm going to stay here for a few minutes after the forum, and if anybody wants to talk to me, we can exchange emails. That would be great. Thanks.
Up, folks. One paid non-political advert. Laurie Fuston, I mentioned, is up from Bellingham. She has an annual event down there on the 17th of August. All right, and it's a memorial swim. And this year, besides an American serviceman and their son, they're going to honor a Canadian serviceman. And I'm going to go down and visit. And so there's some cultural differences, but there's a lot of commonalities in terms of the pain. And I think keeping in touch is an important aspect of mutual support in this.